Craniectomy, bone flap craniotomy, transtemporal, mastoid, for excision of cerebellopontine angle tumor. Combined with middle/posterior fossa craniotomy/craniectomy. Using a transmastoid approach, the physician incises the scalp and removes a bone flap. The tumor is identified and excised. The bone is replaced and stabilized. The scalp is anastomosed and sutured in layers. Craniectomy, trephination, bone flap craniotomy, for excision of brain tumor, supratentorial, except meningioma. For excision of meningioma, supratentorial. For excision of brain abscess, supratentorial. For excision or fenestration of cyst, supratentorial. The physician incises and retracts the scalp and removes bone over the area of the tumor, abscess, or cyst. The bone is replaced and stabilized. The scalp is anastomosed and sutured in layers. Craniectomy or craniotomy, decompressive, with or without duraplasty, for treatment of intracranial hypertension, without evacuation of associated intraparenchymal hematoma, without lobectomy. With lobectomy, a temporal end craniectomy site is opened first and hematoma removed for immediate decompression of hypertension. The dura is closed primarily, or duraplasty may be done with a pericranial or fascia lata graft. The dura is tacked around the craniotomy margin and to the bone flap, and a drain may be placed and brought out through a separate incision. The scalp is closed in layers. Decompression of orbit only, transcranial approach. The physician incises the frontal scalp area and retracts the scalp posteriorly and the forehead anteriorly. The frontal bone is cut and removed. The forebrain is retracted until the superior margins of the orbit are visualized. The roof of the orbit is decompressed after ensuring freedom of movement of extraocular eye muscles. The dura is closed, and the bone is replaced. The forehead and scalp are reanastomosed and sutured in layers. Subtemporal cranial decompression, pseudotumor cerebri, slit ventricle syndrome. The physician performs a subtemporal cranial decompressesion for benign intracranial hypertension, pseudotumor cerebri, or slit ventricle syndrome. Slit ventricle syndrome is a complication following shunting for hydrocephalus. The physician incises and retracts the scalp over the temporal area to be decompressed. A bone flap is next elevated by a series of burr holes made with a trephine connected to a saw or with a high-speed drill and footplate tool for protecting the durum mater used to make cuts around the bone flap margin. When intracranial access is gained, the pressure within the skull is relieved and the bone is replaced and secured to neighboring bone. The scalp is sutured in layers. Other cranial decompression, posterior fossa. The physician makes an incision in the midline extending from the posterior mid-scalp to the mid-cervical region. Dissection is continued to the skull. Drills and saws are used to open the occipital bone to enter the posterior fossa of the skull. The brain is decompressed by removal of blood and pathological tissue. The occipital bone is secured with sutures, wires, or plates and screws. The scalp and neck are sutured closed in layers. Excision, intra and extracranial, benign tumor of cranial bone, e.g., fibrous dysplasia, without optic nerve decompression. With optic nerve decompression, the physician removes an intra and extracranial bone tumor. The physician cuts and retracts the scalp overlying the affected bone. The affected bone is resected and removed. The bone is fastened into place and the scalp is reanastomosed and sutured in layers.